Omaha Mom Talks, proudly sponsored by Day Ventures Swim School, where giggles and goggles unite. Welcome back to Omaha Mom Talks. I'm your host, Jessie Gutierrez. Today, we are diving into a topic that so many women quietly struggle with but rarely get enough support or information: perimenopause. For the majority of women, no one is really preparing us as teens or young women and coming to us and saying, hey, here's what you should know about your hormones. Here's what's likely to happen. Here's what to look for, and here's how to care for yourself. Instead, many of us are blindsided. Our 30s and 40s can feel like puberty 2.0. Hormones are shifting, moods are changing, and we're wondering, is this stress or is this something else? Joining me today is someone who brings both expertise and approachability to this conversation, Dr. Jaime Seeman. You may know her as Dr. Fit and Fabulous. She's an OBGYN here in Omaha, a mom, a wife, and a passionate advocate for women's health, hormone, and self-advocacy. Today we're talking about perimenopause and what our mothers didn't warn us about. Let's get into it. All right, Dr. Seeman, thank you so much for being here today.
Thank you for having me.
Yeah. I would love for you to just introduce yourself, share a little bit about yourself and family life to our listeners.
So I work every day as an OBGYN. I am born and raised in the state of Nebraska. I've never left. I say if it's not broke, don't fix it.
Okay.
But I have 3 daughters who are 10, 12, and 14. Okay. So I'm a mom and my girls keep me extremely busy. But I not only work as an OBGYN, I wear a lot of other hats, a lot of other things that I do.
Tell us some of those.
Yeah, I'm a team physician for our local Omaha Supernovas professional volleyball team. I run a social media, Dr. Fit and Fabulous. I've got a book and a podcast and do a lot of speaking. And my life is busy, but I love it. And I wake up every day happy to just hit the road and go.
That's awesome. Tell us the name of your book and your podcast.
So I wrote a book several years ago called Hard to Kill, and it is about my personal journey going through my own health struggles as a human and as a mom, and coming to this realization as a physician that we're humans too, and we're patients too, and we live and breathe the same struggles that our patients do to stay healthy and maintain our, vitality and longevity. And I had a very personal experience in 2015 where I lost one of my best friends. And that was kind of like an awakening for me that, life is really precious and really short. And it renewed a sense of gratitude and gratefulness for whatever time I have here on earth.
Yeah.
And I went on this personal journey, and it really opened up my life in ways that I never could have imagined. And so I wrote this book just about what I did, and so much of it too was a lot of just behind the mindset of how to, reinvent yourself and find yourself and become the best possible human that you can be. And so I wrote a book, and it's very it's not super sciencey.
Okay.
It's very basic. Anybody can read it. I wanted to write it my girls were younger at the time, but I kind of said I want to write it so my 10-year-old daughter can pick it up and understand it. Because I think sometimes, doctors are really smart people, and sometimes bringing it to a level where you can connect with everybody, that was really important to me.
Yes.
But it's just a very basic guide for how I live my life, and how the way that I take care of myself allows me to do all the things that I do.
Okay. I love that. I call it Hard to Kill.
Hard to Kill.
And your podcast?
And my podcast is the Fit and Fabulous podcast.
Okay.
And it is a whole range of topics. I mean, everything from, women's health to biohacking, everything in between, but it's things that are exciting to me and things that I think would resonate with listeners. And it's been a fun little project.
Awesome. Very cool. And we in my family, we're huge Supernova fans, and I have 2 little girls. They're 4 and 7. And so I love that you are their on-staff physician, that's a female physician caring for them. And that I just love when my girls go, like we're watching these pro women athletes. Like
they are incredible
I'm so
people
impressed.
And incredible athletes. And it's been really fun to be involved because this is literally kind of a ground up movement in women's sports.
Yeah.
We've had basketball, and we've had other sports, but volleyball is a huge sport,
Yeah.
and professional volleyball has never been able to, dig its claws in a sense, in the US. It has
Yeah.
internationally. And so to watch these women be able to play here in the US in front of their families, in front of these fans. My girls don't play volleyball, but even they love sitting there and they connect with these women, and
Yeah.
to see what they can do it's been so fun to be a part of it.
Yeah. I love that. Well, as you were talking about all of these hats that you wear, OBGYN, author, speaker, social media, physician for the supernovas, you wear so many different hats. And I always wanted women to feel I want to be transparent about like, yes, we can do it all, but we need systems and support in place to be
Yep.
able to do it. And so, if you could share with our listeners, like, what are some of the formal or informal systems or supports that you have that make you like, because I always say, like, I wouldn't be able to be good at my job if I didn't have quality childcare.
Right.
Like, if I don't know my kids are safe and in well hands, like, I can't show up and listen to people's trauma and distress, right? So, what are some of the supports that you have in place to make it
100%.
all work?
Well, my partner, my husband, is my biggest support.
Okay.
I
And what's
mean,
his name?
Ben
Okay.
is his name. He worked as a police officer for 15 years. So our life has really shifted. He kind of quote unquote retired because we opened a business several years ago
Okay.
out in Elkhorn called Upgrade Performance Institute. And that allowed him a lot more autonomy of time to be a dad and to be a supportive partner for me as
Yeah.
well. But he is everything. I mean, my schedule is crazy, but he really carries the load of, when the kids have to be at practices, when the kids have to be at school, because his schedule is way more flexible than
Okay.
mine is. And he does that role just absolutely amazing. He also has support from my mom. So we had our three daughters when I was in medical training,
Oh, wow.
and he was working nights as a police officer. So our schedule was absolutely crazy. I mean, we're coming, going, like
Two
he's
shifts
walking out the
possible.
door, I'm walking in the door, but we made it work. And now that the kids are a little older, they can put their shoes on, they can make their breakfast. That's, given us a little bit of breathing room. But both of our families are close by, and we
Okay.
have really leaned on them through, certain chapters of our life to help with the kids and support us in ways that we need. And my mother is a godsend. She these days is a certified Uber driver because there's three of them. And so even if I am available, I mean, let's be real, we can't be three places at
Yeah.
one time. So we have been very fortunate that we've been able to raise our family close to our parents,
Yes.
and have definitely utilized them. When it comes to just like living life, I do some meal services sometimes.
Hmm.
Sometimes I have frozen meals that I have ordered and prepared to kind of streamline that process. I've really also tried to involve my kids in cooking and preparing meals,
Great.
because I think that there's a lot to be learned when, you have to do the work to, get the food on the table.
Yes.
Same goes with laundry. The girls are finally getting to an age where we have a set day of the week where it's your laundry day this day, your sister's is the next day, and your other sister's is the next day.
Yeah.
And so I think, involving your kids in those things. And I think sometimes as a mom, you feel like I have to do all of these things. Like that's the mom's role.
Yeah.
And I've just been really clear and transparent with the family. Hey, this is what I have the capacity to do. Where can everybody else, help
Hmm.
out? And let me be real, my kids are not perfect. They,
Yeah. Yeah.
we sometimes have to reinvent the systems, in a sense. But I think the other thing that I want, people to hear is that I also structure my day in a way that I really do prioritize myself first, and my health first, and my mental health and my physical health and my spiritual health, because as a mom and as a doctor and all these different hats that I wear, we cannot expect to fill everybody's cup if our pitcher's empty. And so my kind of motto that I've used through the years is called pay yourself first.
Okay.
And it means that when I wake up at 5 a.m., the first thing I do is I head to the gym, and it's my hour to move my body and to get ready for the day and to kind of set the tone for the day. And that time outside of delivering a baby is my time, and I get to go do that. Um, but I think so many women, struggle to find ways to really, we call it self-care. And I
Yeah.
think when people think of self-care, they think like it's scheduling yourself a pedicure,
Spa day.
or a spa day, or those things are amazing and important as well. But, I think eating right and moving your body right and giving yourself time, whether it's, meditation or breath work or, getting a babysitter for a night so that you can kind of, unplug from the rat race in a sense. I think those things are the most important things that I do, because it would be very easy to get burned out,
Yeah.
juggling all the balls. And we see it every day,
Totally.
especially in
Yeah.
what you do. It's
Yeah.
very overwhelming. And so people always ask how I do all of what I do. And really, sometimes I don't even have the right answer. But I really try to take care of myself in a way that allows me to recover fast,
Yeah.
because I love my life. And I don't want to, sometimes my husband will say, well, maybe you should just take a few things off your plate. And sometimes that is the right answer. But I think that we have capacity as humans to do a lot of things. And you just have to, just like a car, if you don't change the oil and you don't do the maintenance and you don't get new tires every 50,000 miles, like it's not going to run anymore.
Yes,
So,
absolutely.
yeah.
And I love that message of just taking care of yourself first, because with so many of the women that I support, I hear this word selfish.
Mhm.
And that is, I mean, there's so many reasons, just like why we've been kind of programmed to think that way.
Yep.
Women are martyrs, women have to
Yep.
do it all, XYZ. But what I am constantly telling women is taking care of yourself is taking care of your family. Because I know when I'm not taking care of myself, I have less patience. I'm a little more irritable,
100%.
cranky, right? And so those are always good signs to me of like, oh, I need some me time. I need some time where I'm just pouring into myself and not thinking about what someone's going to eat or what
Yeah.
what shoes fit and don't fit and just all of the things. So,
And I think, I always like imagine, your brain's like 100 browsers that are open. And everybody has different personality types. But one thing I've really tried to focus on over the last several years is like when I'm home and when it's mom time, it's mom time,
yeah.
right? And it's like, put the phone down, connect,
Yes.
when I'm at work, I'm in that mode.
Yes.
And not letting those things spill over into the other, aspects of your life. But it's hard to do. It
It's so hard. And that's
takes
something,
focus and intention.
yes,
Sure.
being present is something I'm always working on and sharing with the moms that I support. Just like you said, we're human too as providers. Like we know kind of the guidance and the best steps, but we're
Yeah.
trying to implement it too in this parallel life with our patients. But I'm right there with you.
And I think your kids are watching too.
Yeah.
I think of what it was like to be a teenage girl, and they watch the way that you connect with your partner. They watch the way that you go to work and come home, and it's such an important time in their life, and so many things for them to be learned by watching you,
Absolutely.
do it.
Absolutely. So I'm super excited to jump into this chat with you about hormones and perimenopause. So I work as a maternal mental health therapist, and a lot of my perinatal clients are so rocked by this pregnancy and postpartum period,
Yeah.
right? There's so much going on. And so I support a lot of these perinatal patients who we find what I call recovery, right? We find some relief in their symptoms and then they don't need me anymore.
Yeah.
And then oftentimes, handful of years later, I find that these women are coming back to me and they're saying, okay, Jessie, like I just don't feel right. I feel some of them say, I feel crazy. I feel like just not myself. I know this isn't postpartum because it's, I've been.
My kids are 10.
Yes.
Yeah.
Yeah. Or even 5.
Yeah.
Like,
Yeah.
and I went and got my labs done and my provider said, all good. Everything's in range. And I'm just seeing this more and more and more. And then, hello, I'm living it too, right? And I feel like so much is on our radar about this. So I want to have this chat with you and let's just start with the basics, if that feels okay. So
Yeah.
first, just tell me what exactly is perimenopause and maybe how is that different from menopause?
Yeah. So when you are born, as a girl, you have ovaries, and your ovaries contain a bunch of follicles or eggs. Essentially, a female baby is born with all of these little eggs, and then as you become a teenager and you go through puberty and you go through something called menarche, that's essentially the medical term for your first period. So you've now entered your fertility, your years of fertility, and you go through these years and you have your babies, but you have a cycle, right? You have a menstrual cycle. And what happens in a menstrual cycle is you kind of get these 2 weeks of estrogen production and progesterone production. And as that follicle pool in the ovary starts to diminish, and this happens at a different time in everybody's life, there's a multitude of factors that will decide when that happens. There definitely is some genetics, at play.
Okay.
But another thing is lifestyle. So the ovaries, the aging of the ovaries is essentially pacing the aging of our bodies.
Okay.
So when we have, maybe we smoke and we're not getting good sleep, or we have metabolic disease like diabetes or high blood pressure, these things can actually increase the aging of the ovaries.
Really?
Yeah.
My poor ovaries.
And so what happens is as this follicle pool starts to diminish during these menstrual cycles, we start to see some dysregulation of estrogen and progesterone production. And these are our sex hormones. And they're not just for reproduction.
Right.
Estrogen does a lot
Yeah.
of things in the body. We have estrogen receptors in our bones, in our brains, in our ears, in our blood vessels. We have them everywhere.
Yeah.
And so what happens as you enter perimenopause, the definition of menopause, literally peri means around, so around menopause, there's kind of this 3 to 5 year off ramp into menopause.
Okay.
The clinical definition of menopause is no period for 12 months. You can also check a lab that will tell you that, but really clinically as a provider, if a woman hasn't had a menstrual cycle in 12 months and she's around 45 to 55, it's probably menopause.
Yeah.
Yes.
And there is a specific test for menopause.
Well,
is that what I heard you
yes
say?
and no.
Okay.
Yes and no. There's something called follicle stimulating hormone, and this is a hormone that's secreted from the pituitary gland in our brain. And this hormone is the one that is stimulating the ovaries to grow these follicles for ovulation. And as that follicle pool starts to diminish, there's just not as many good quality follicles left in the ovary. The pituitary gland starts screaming louder. It's like, hey, ovaries, come on, we need a good one, right? But there's not many people left at the party.
Mm-hmm.
And so it starts screaming louder and louder and louder. And so that FSH level will start to rise.
Okay.
And when the FSH level gets above about 23, that can be indicative of menopause. Now, here's the caveat with that for every woman listening that wants to ask their doctor to check labs, is that you probably need to check that level multiple times and have it be consistently over 23 to tell a woman she's menopausal. Because if you come into my office in perimenopause, I might check it this month and it's 25.
Yeah.
And then all of a sudden next month, you had an ovulation and the FSH is lower. So you have to use that information along with information about what is actually happening with the menstrual cycle. Is she actually missing periods? Now, if a woman's had a hysterectomy or an ablation, or she has a progesterone IUD in place, maybe she doesn't have a menstrual cycle because of that. So it really takes a lot of clinical sense to kind of say, okay, I think you're in menopause. But there's not a one-time test to say you're in menopause.
Okay.
Because month to month it can change.
Okay. And for perimenopause, so this, I feel like it's kind of a buzzword. I don't know if you feel the same.
Well, it's becoming a hot topic, and for good reason, because women's health has not been well studied.
Well, yes.
And the reason it has not been well studied is because of the menstrual cycle is very confusing to scientists and clinicians because it is literally changing hour to hour, day to day, week to week, month to month, year to year. And so to be able to study it is very difficult because even woman to woman, the levels are going to be different.
Yeah.
And because it changes so much, you can't check a one-time lab. I mean, if I wanted to know what your blood count is, it's very easy. I can draw your blood right now and tell you your hemoglobin's 12.1. But when it comes to hormones, they're in flux so much that it's difficult to do just a test.
Well, and I feel like that is something that I'm hearing is frustrating for some of the women I support where maybe they're OB. And I don't know if it's an insurance thing, if it's a time thing or what it is. So maybe you can shed some light on that. But like I would have to test your hormones a whole month to get like a clear picture. And one, like you might not have that time. I don't know
Well, it kind of depends what you're looking at. So, for instance, if you come into your doctor's office and say, I want to get my hormones checked, if you are a menstruating woman, we need to know where are you at in your menstrual cycle? Because in the first part of your menstrual cycle, your estrogen level will be one thing, and the second part, it would be a whole nother thing. And so if I didn't know where you were and I just checked it and I was like, oh my gosh, it's 600, well, that would be indicative of ovulation, but maybe that's not really where you are in your cycle, and you truly have a sky high estrogen level that needs addressed. And same goes for progesterone. I actually see this very commonly. I would love for women to listen to this and listen to it twice, because there's a lot of hormone clinics and things like that around town, and women will go in and get it checked, and they'll come and say, Dr. Seeman, I have a low progesterone. I think I need to go on progesterone. And I'll say, well, when did you have these drawn? And when we look at it, they had it drawn in the early part of their cycle. That's a very normal time to not have any progesterone. You really have to find that progesterone peak around cycle day 21 for most patients with an average 28-day cycle. So when you get your hormones checked, they have to be interpreted in a way that we can understand where you were at. Now, you can check them. You don't want to get your blood drawn for 28 days straight. I haven't found anybody that's signed up for that. So there are some testing modalities out there, like a Dutch test, where you can urinate on a strip of paper every single day of the cycle, and you can do something called cycle mapping. Now, that can be helpful, but remember, the menstrual cycle changes every month. So we're only seeing what happened with this cycle. There are some direct-to-consumer tests now where you can get this little device at home, and you can urinate on the strips at home, and it will actually track your FSH, LH, estradiol, progesterone levels from home on this little device. Of course, they're not super cheap. You know, the strips can be expensive, but we're finding new ways. I mean, we see the Oura rings and the Whoops and all of these things. They don't directly measure hormones, but I think we're finding so many more things where women can now kind of get a lot of information on their own at home. But of course, you need a clinician and somebody with a lot of experience to kind of interpret really, what's going on.
Yeah. And one thing that I heard you say, and I just want to clarify for listeners. So if, because there are a lot of hormone clinics and places, and so if I and the average person is looking to go get my hormones tested at one of those places, it sounds like having a provider there that understands my cycle and testing, and it's not just like let's test on a random day.
And the unfortunate part is, because menopause and perimenopause have become such a huge thing, we're seeing a lot of these hormone clinics pop up. And I'm going to say this in a very professional way, but some of the, providers at these clinics are salespeople. They're selling compounded formulations or pellets or things like that, and they're a business, and they're selling hormones. And so I've unfortunately seen a lot of patients that have been led astray that, oh, your hormones are low, just, take these hormones and everything will be better. And there's more is never better. And so sometimes, I see the side effects and ramifications of patients that have been mistreated. And it can be easy, right? When you don't feel good, to just think that this is, the magic. But there's so many more pieces to the puzzle than just replacing the hormones, that most women don't get that portion addressed. And so, you really have to find a trusted provider that has a lot of training, that has a lot of experience in this. There's a few places patients can go look. The North American Menopause Society does have a board certification process. And so you can go, it's called NAMS, NAMS, North American Menopause Society. They have a provider finder, and there are people here in Omaha that are North American Menopause certified. There are some that aren't certified that are still fantastic. But, talk to your girlfriends and people and trust, and find somebody that you trust too. Because there is a lot of nuance when it comes to, treatment of hormone replacement therapy.
And I appreciate that resource, because in my practice, I'm, part of my job is giving people resources, and I'm so protective of my people. And so I'm always listening to what my girlfriends or what the mom groups or what my patients are talking about. And I'll hear about a hormone clinic that somebody loves, and then I hear the opposite, and I don't know because I'm not going. And so knowing that there's, a resource where they can find well-trusted and trained providers. And like you said, not everybody's going to be on that website, and they still may be wonderful.
And from a cost perspective too, I mean, although a lot of things in women's health have not been covered well by insurance, this is something that, your insurance should cover. There are bioidentical hormone options that are covered by insurance. And so I hate seeing women sometimes, dump hundreds and thousands of dollars sometimes into crazy testing or treatments that probably aren't serving them in the best way.
Okay. So let's chat a little bit about. I know that everyone's kind of perimenopause journey can show up differently. And I hear a lot when folks are coming into me saying, I don't feel like myself. Some of the symptoms I'm hearing are like, I have brain fog, my words aren't coming to me as fast. Maybe there's like headaches or migraines, insomnia, belly fat. For you as an OBGYN, what are some like symptoms that make your ears perk up that you because, right, you're assessing so many different things like
Mhm.
mental health, PMDD. Like, so when someone comes into you, what are the things that make your ears perk up that you're like, oh, I think this is hormone related?
Right, because there is organic sleep problems. There are mental health problems, metabolic diseases. And so when I'm listening to a patient, I'm trying to decide, do I think that this is from hormonal dysregulation or do I think there's some organic issue? Because if they have an organic issue, we need to treat that first and not just brush this off that it's, perimenopause. What happens though in perimenopause, kind of back to the physiology of it, is that when this follicle pool starts getting small, estrogen levels become really erratic. So they're shooting sky high, some months they're low, but they're really bouncing up and down like big time. If I drew a little chart for you, I would call it psychotic because it's literally up and down, up and down. But month over month, year over year, the estrogen levels are kind of trending down. And so some months this patient feels really, they're like, oh, back in June, I felt really good. And then in
Okay.
July, oh my gosh, it was a horrible month. And then the same thing goes with the progesterone levels. Ovulation becomes inconsistent. So some months they're getting the progesterone, some months they're not getting as much progesterone. But month over month, year over year, these things are kind of trending down. And so when a patient says, all of a sudden over the last 9 months, it's been kind of this progressive thing. I'm sleeping really poorly. I can't sleep. Now I'm having to, use more caffeine because I'm tired because I'm not sleeping well. Hot flashes and night sweats are like the big red flag, which we generally don't see until a woman is like really making that menopausal transition. And when they have that last period, they don't know, right? Is this going to be the last one or is another one going to show up in 6 months? But once they make that transition, that very first year after the menopausal transition is usually the worst for those types of vasomotor symptoms, hot
Okay.
flashes and night sweats. But sometimes in perimenopause, we start to see it in a month where they had lower estrogen. They're like, Dr. Seaman, I woke up, I was like sweating, like throwing the sheets off. I start to see sleep disturbances become one of the first things that happens in perimenopause.
Okay.
Brain fog, sometimes it's really subtle. Like women will say, like, I put my cell phone in the fridge. Like,
Mm-hmm.
very silly things where you're like, whoa, that's not me,
Mm-hmm.
And that's because with reduction of estrogen, we see about a 30% reduction in brain energy. So our brain is literally not efficient at finding the fuel sources it needs to go. And so that's why it feels slow. Like I can't remember that person's name. I don't remember where I put my keys, these types of things.
Yeah.
And it can be unnerving because
Yeah.
women can be very self-aware that that's happening, right?
Yeah. Like
Um,
I'm normally pretty sharp. And so this
yeah.
is like a big contrast.
Yeah. We also start to see reduction in engagement in the sexual aspect of the relationship. They're like, I'm either having trouble with arousal or I have no libido at all. My husband and I are great. Our relationship's good. Life is good. But like, I don't really care to engage in the sexual part of my relationship. That is definitely multifactorial for women, but that's another common complaint in perimenopause. But really, the biggest one that I hear is women are like, I can't lose this 10. I used to be able to just lose this 10 pounds. I knew it was because I was having too much wine and went on vacation. But women will start to say, I'm trying to exercise, I'm trying to clean up my diet, but I can't get this weight off. And a lot of it tends to be central. They'll
Mm-hmm.
say, my pants just, feel tighter. And the reason that that happens is because with loss of estrogen, we do see metabolic changes within the body that start to create more insulin resistance. It starts to create more what we call visceral fat deposition, which is the more dangerous type of fat. You and I are talking about the symptoms that are going to make moms feel better,
Yeah.
right? And just show up in the world. But when you start to lose your hormones, we start to increase the risk of diabetes, high blood pressure, osteoporosis, particular types of cancer, dementia,
Heart health.
heart health,
Yep.
yes, cardiovascular disease. And so, um, that's the nuance with perimenopause is, does this patient have a true issue we need to address, or is this just related to what she's feeling from this reduction of hormone production?
Mm-hmm.
Yeah.
Okay.
Yeah.
And as we're talking about estrogen, I also, kind of on another side of the coin, am hearing a lot about estrogen dominance. So when we have high levels of estrogen, what are some of those symptoms that women with high estrogen might see, and what are some of the risks
Yeah.
for them?
So estrogen, when it comes to like the uterus, is a proliferative hormone, and progesterone is anti-proliferative. So when you get into a state where you have lots of estrogen and a lack of progesterone, a big one is changes in the menstrual flow. So women will
Okay.
say, "Oh my gosh, my periods are so heavy.
Yeah.
I'm going through tampons every couple of hours. I'm having to change my Diva cup or whatever it is." But heavy menstrual bleeding is a big red flag for too much estrogen and not enough progesterone. And,
Okay.
and that is important too. Sometimes it's not that you have crazy amounts of estrogen. Maybe it's that you're not ovulating consistently and not making enough progesterone. Or maybe you are and you are pumping out crazy levels of estrogen. Estrogen is made from the ovary, but estrogen is also made from our androgens like testosterone. Actually, all of our estrogen is made from testosterone, but sometimes it's at the ovary and sometimes it's in our fat cells. So when we carry extra body fat, extra body weight, we convert a lot more of our testosterone into estrogen. And so there can be a lot of reasons why women get high levels of estrogen, but signs of estrogen dominance would be heavy menstrual bleeding, sometimes growths of the uterus, like a fibroid or a polyp or something like that, breast tenderness, breast heaviness. The breasts are very sensitive to those estrogen levels. Sometimes you had mentioned headaches or migraines. High levels can sometimes cause problems there. Um, and we've talked about the nuance with testing. It's hard sometimes I will sometimes get lucky and I'm like, oh my gosh, her estrogen is 600. That's like, crazy high. Um, but it can cause a variety of symptoms. And perimenopause and menopause in particular are a time of estrogen dominance. We see it, physiologically that women produce more estrogen than relative to progesterone in this transition. And these are some of the things that patients may start to experience.
Okay. It's all so interesting too, because I went to my OB, who I love, and I was telling her like all my things, all of my ailments, and I said, "I think I have high estrogen." And should we test? And she's like, "No, I already
Yeah.
know you do."
Yeah.
Like based on everything you're telling
Right.
me,
The
right?
clinical picture sometimes will give you the diagnosis. One of the things they teach you in medical school is listen to the patient, they will give you the answer.
Yeah.
And I think it's really validating for women to get their blood drawn and to like see
Yeah,
these
absolutely.
things. And sometimes that is necessary. But if you are with a clinician that has been doing this long enough, a lot of times the patient will give you the answer.
Yeah.
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 And I trust her, right?
Yeah.
That's why I keep going to see her. So what about then I'm also hearing from some of my women in their mid 40s ish on up about having low testosterone. And so chat with me a little bit about like what may make me think that what symptoms might I have, and why might supplementing be a
Yeah.
good idea?
So testosterone is made in the ovary. Women actually make more testosterone than estrogen, even though we think of
Oh,
testosterone as a male hormone.
yeah.
But our testosterone then gets converted into estrogen through a process. There's an enzyme that makes that conversion. When we go through perimenopause and menopause, testosterone does not always go low, like estrogen and progesterone.
Okay.
It does not always go low. So not every woman needs testosterone replacement. But testosterone is an important hormone for women. The one symptom that most patients will pursue testosterone replacement is for low sexual desire. So we call it hypoactive sexual desire disorder. It means I want it more. Men, their sexual function is very driven by testosterone. They have a normal testosterone. They wake up with morning erections. They think about sex multiple times per day. Women tend to have more responsive desire,
Yeah.
meaning they need some sort of arousal first.
Yeah.
But it's this perfect storm, right? Estrogen's going down, progesterone's going down. Maybe they aren't making good testosterone. And then we start to see this sexual dysfunction. But testosterone does other important things. It maintains our lean tissue mass and our bone mass. It's a very anabolic hormone. And those are big problems that women experience going through perimenopause and menopause. It helps with sleep. It helps with energy. But more isn't better. So when women are thinking about testosterone replacement, you do want to check the levels. You want to know what the total testosterone is. You also want to know what the free testosterone is, because women, when we, maybe they're on a birth control pill, or maybe they have crazy levels of estrogen, that can change a protein in the blood called sex hormone binding globulin that can bind up your testosterone. So it's like a little carrier. And if it's holding on to all the little, kids in the line, they can't get out to recess. So when you check testosterone, there are a few different things you want to be checking. And I find some women with literally a testosterone level of 0. But then you have to ask yourself, why is her testosterone 0?
Yeah.
And it can be from insulin resistance and obesity. It can be from overconsumption of alcohol. It can be from poor sleep. It can be from lack of exercise. So it always seems like the easy fix to just go on testosterone replacement therapy. But there's a reason why it's low, and you really should try to address that kind of root cause before you just throw testosterone at people. Testosterone is not an FDA-approved therapy for women in the United States, which is a whole political conversation, because it's approved for men, and it's actually very cheap for men. I find men that can get their TRT for $0 a month at the pharmacy. And for women, it's cash pay. And that's unfortunately where a lot of women will get lured into hormone clinics, with these cash pay clinics and getting sold testosterone. But I do find it's about 50-50. Some women respond really well from a sexual health aspect to testosterone. They feel more energized, they're sleeping better, their sex life is great. And some women don't. And that's because women are just a little bit more complex. When it's not just testosterone, it's estrogen, it's progesterone, it's how she's eating, it's how she's moving, it's how she's sleeping. All of these things will impact her symptoms. And the other thing you have to be very careful about with testosterone is because it is a androgenic hormone, it can cause acne, it can cause oily skin, it can cause androgenic hair loss. You can get enlargement of the clitoris. So you really want to make sure, if you're doing testosterone replacement therapy, that you're monitoring levels, that you're getting appropriate, dosages of this, because more is definitely not better. Women do not like those side effects. I can tell you that.
Yeah. Well, and it's interesting for me, and this is just subjective experiences, but the women that I know that have done testosterone supplementing, they're like, it is life changing. And it ain't about the libido, because they're not going for that. The women that I know, they're going because, and they're like, I have more energy, my brain is clearer, I don't need my 3 p.m. Alani. And so then that's led me to be like, I want to feel more energy. And so I went and got my labs done, and they were like, your testosterone is mid. Like, it's, you could supplement or you couldn't. And so then
normal testosterone is like 10 to 40, but the tough part is, even though 10 is normal, 40, that's literally 4 times 10. Right?
Oh my God. I think mine was 7. Maybe I do need to supplement. I don't know.
But you want to look at the free testosterone too, because sometimes, you have might be a lower total, but there's a lot of free testosterone. And so you're not as symptomatic from it. But there's always this question, and I think it's a buzzword on social media, of what's the optimal. And we don't know, right? For each of us as an individual. But sometimes I'll say to a patient, it's in the normal range, but it's kind of low. Why don't we do a little bit of replacement and see if your symptoms improve? Because if we get you into, the upper normal range and you're not feeling better, then it probably wasn't your testosterone, right? But sometimes we do that and they're like, oh my gosh, this is life-changing. I feel so much better. And also addressing those other important factors that are going to support her testosterone
their
production.
lifestyle.
Yeah, exactly.
Yeah. So, as I mentioned, so many of us, our social media feeds are just filled with chatter about wellness and hormones and perimenopause. And honestly, women just want to feel better, right? And I was saying earlier how so many of the folks that I'm seeing are telling me, I got my labs run. My provider said, like, I'm in range, I'm all good, but they're screaming to me, I don't feel fine. So, what can these patients do when they're feeling maybe dismissed or brushed off? What are some next steps, either for advocating or researching?
It can feel really defeating. I actually had a patient just yesterday in clinic. We finished the visit, and she said, Dr. Seeman, I just want to tell you, thank you for listening to me. And I think so many women, even if the solution is not what maybe they thought when they came in, I think women just are very much dismissed. And this has been a problem in women's health for a lot of years, right? It's like, oh, you don't feel good, just take a birth control pill. Or, they've really kind of been gaslit in a sense because
Yeah.
there there isn't a lot of research. And so there aren't a lot of clinicians that understand the solutions for these women. And I think that women, the cool part about social media is, for better or for worse,
Yeah.
we're getting better dissemination of information. There's been some amazing books put out by some of my friends and colleagues in the last several years. And literally, I've had patients come in and they're like, I read this book by so and so,
Wow.
and I want to talk about these things.
Cool.
And so I think it's really cool that we're starting to see that conversation open up. But there are some providers out there that just, they don't do hormone replacement therapy. They don't want to take care of perimenopause and menopause. And so sometimes you do have to advocate for yourself in a sense of, okay, I gotta go look. I have to find a provider that's
Yeah.
willing to like first just listen
And
to
honestly,
me.
I don't blame those providers. Like as an OBGYN, there's you can't be
We
a
do a lot of
specialist in
things. We do a
everything
lot of
in women's
things.
health. Same as me as a mental health therapist. Like there are certain things like I always if I get a referral for anything to do with eating disorders or substance abuse, I have like the most basic training on those things. You don't want me. I'm not a specialist.
Yeah.
You deserve a specialist.
Yeah.
And so if our providers I think can be honest and say like, "Hey, I'm going to refer you to someone else." Like, do I know a little bit about that? Yes, I do. But do I know a lot about that? Not really. And you deserve somebody who really knows a lot about that.
But I think the other tough thing for people to hear, what I'm about to say too, is that we have to take some self responsibility and accountability. Although we don't feel good, am I doing what I can do to make me feel better?
Yeah.
Because your doctor can give you, they can give you a prescription for hormones, or they can give you all the information you ever need. But sometimes when I really start to dig in with women, it's like, okay, maybe you're not taking care of yourself in the best way. Let's try to optimize some of those things first and see what improves. Because I think, we're always looking for that quick fix. And
Yeah.
that's just us as a culture. We've been that way for a long time.
Yes.
And sometimes there isn't a quick fix, and you have to understand that that's an okay answer too, that this is going to take some time. We're going to have to, look at your sleep hygiene. We're going to have to start, fixing your diet in certain ways and moving your body in different ways than you've never done before, because perimenopause is the time to double down on lifestyle.
Yeah.
You don't have the resiliency that you had in your 20s and 30s to some of the choices and behaviors that you made.
Mm-hmm.
And you really start to feel it in perimenopause because you don't have the resiliency. You don't have, and it's not just sex hormones. So you're losing growth hormone. You're losing a lot of things. There's
Mm-hmm.
something called cellular senescence, and that's our cells aging. And to this day, as a medical provider, the scientists are trying to we would love the magic youth pill, but we don't have it quite yet.
Yeah.
So, but women do, they have to take a little bit of self-responsibility, advocate for yourself. If you don't feel connected with this provider, find a new one. There are so many great resources and books and podcasts and things like that where I think women can learn a lot of information on their own,
Mm-hmm.
and just use the provider for what they're there for. And that's, when you need hormone replacement therapy, you do need a good provider.
Yeah,
Yeah.
absolutely. Well, and I think one of the things that I just want to validate for women that are listening is that so often we are delaying even making the appointment. So we're already feeling extremely shitty. And then we go and this is common. Like so you're not alone if you do this. I see it all the time. And then we finally make the appointment. Maybe like the kids are back in school and I feel like,
Yep.
"Ooh, I have a moment and I can make this appointment that I've put off forever." And then I go to my provider and I'm really hoping for some relief and some answers. And they tell me, "Labs are great. See you
Yep.
in a year," or whatever. And so I'm always encouraging women, like, don't give up. Don't just leave it there. Like, you
Right.
deserve to feel good.
Well, and we talked about the nuance of lab testing. I mean,
Yeah,
sometimes it looks good now and it doesn't later. So,
right.
just because today it looks like this, it doesn't mean that what you're feeling isn't real.
Right.
You caught it on a good day. And so sometimes, like I said, it takes, testing a few different times, and really kind of tracking the symptoms. Because,
Yeah.
like I said, some
Yes.
months you feel good and some months you feel bad.
Please, ladies, track your
And so
symptoms.
one time I told a patient, her labs they looked really good. And I said, I want you to call me on the worst day of the month. I'm going to have you come back over and we're going to draw them, right? Because we need to correlate how she's feeling with what we see. But we caught her on a good day and she did. She came back and it was super low. So sometimes you have to advocate and you have to just keep looking and searching.
Yeah,
Yeah.
yeah. And tracking your symptoms is huge. I think that if you're not keeping notes in your phone or in your journal or whatever,
Yeah.
please start doing that, because your doctor's not going to sit down with you and say, on September 1st, what were your symptoms on the second, right? And so if you're keeping symptoms tracked and you can use that as data to help your clinical provider make an assessment,
It is
that is going to
super
be,
helpful. They're like, oh, it's always the 5 days before my cycle.
yes.
Okay, well that makes sense because that's when your hormones are really, coming down. And so it is important to, if you're a menstruating woman, to kind of say, when are these symptoms happening? What was I doing? That is very helpful to a clinician.
Yes. So the good news is I do feel like there's a lot of chatter and conversation that is happening, like you said, for better, for worse, for social media. But I do believe knowledge is power, and it is giving women the opportunity to, validate their experience and find out more. So I just want you to share with us, what are some of the medical treatments available for hormone replacement?
Yeah, like the
We hear
types of
like,
hormones.
yeah, we hear about like gels, pellets, creams, like
Yeah. Yeah.
what's available and what do
So
you?
years ago, what was available to women is different than what most of us use now. So traditionally, like when the WHI studies came out, most of these women, well, in a birth control pill, for instance, that's ethinyl estradiol. It's a synthetic estrogen that's very potent at the estrogen receptor, but that's not a good way to replace hormones for a perimenopausal or menopausal woman. So in my practice, because I think if you brought 5 other OBGYNs in here, we might all give you a different answer. I only use bioidentical hormone replacement therapy. Now, most people think of bioidentical hormone replacement therapy that it comes from like a compounding pharmacist, that it comes from some natural magical estrogen waterfall out back. I think people have a very confused idea in their head of what bioidentical. Bioidentical is 17 beta estradiol. So you can get it from a commercial pharmacy. It comes in a lot of different formulations. It comes in an oral formulation. It comes in a patch either once a week or twice a week. It also comes in a transdermal gel. It also comes in a transdermal mist. So transdermal means actually putting it on the skin. You can also get 17 beta estradiol compounded from a compounding pharmacist, and they'll either make it in a cream or a sublingual oral dissolving tablet or something called a troche, or you can get subdermal pellets. So you can get 17 beta estradiol, natural bioidentical estrogen, in a lot of different forms.
Okay.
Now, which one's better? Which
Yeah.
one do you take,
Tell
right?
us.
There's a lot of differences in how these things are metabolized. So oral estrogens, same goes for a birth control pill. When you swallow an estrogen pill, it goes down into your stomach and it gets absorbed, and the first place it goes is your liver. And it can change a lot of things in the blood. So it can change some proteins in the blood. It can change clotting factors. And so oral estrogens aren't my favorite. I do use them in certain situations, but it's not my favorite way to replace
Okay.
estrogen. They also change your cholesterol numbers. And because of the increase in clotting factors with oral estrogens, that's the only form of hormone replacement therapy where there's a slightly increased risk of blood clot and stroke. So for any patient, obviously we're talking about an older population, if they are obese, if they have high blood pressure, if they smoke, oral estrogen should, and the clinician should know this.
And if they have like a history of
Any history of
migraines, even, or like the
yeah,
neuro.
mostly with aura. So
Yeah, yeah.
mostly,
I feel like
with
I read
the
that
with
somewhere.
the little flashy floater, more of those types of symptoms with a headache or a migraine, then they may be at a slightly increased risk of stroke. So those patients should not take oral estrogens.
Okay.
So my more favorite way to give estrogen replacement therapy is through the skin. So when you give it through the skin, it does not go to the liver like it does with oral estrogens. It just goes right into the bloodstream, goes to all the little estrogen receptors in the vagina and the blood vessels and the brain, and does what it's supposed to do without that risk of blood clot or stroke. And so I use a lot of estrogen patches in my clinic. The twice weekly estrogen patch is much smaller than the once a week. And so you can wear it on any clean, hairless, area of your body outside of an adhesive allergy. Most patients do great with that. Or if they do, they also make a gel, but the gel is daily. So it comes in these little convenient once a day packets. You can just put it on your skin, let it dry. And that's a great way to replace estrogen. You can put estrogen in a pellet as well. The caveat with pellets is that if I give you estrogen in a patch or a gel, it's more physiologic dosing on how your body, your ovaries would normally be producing estrogen in a circadian rhythm. When you give a pellet, you're giving a 3-month dose, and then you're not coming back to dose it again for 3 months. So you're getting these higher peak levels, which the risk with that is more side effects. So, we could cause bleeding, we could cause breast tenderness. With testosterone, we kind of talked about, oily acne and hair loss and things like that. So the way that your hormones are replaced are important.
Okay.
Now, the other hormone is progesterone. And this is very important what kind of progesterone you're given, because in the older studies that showed an increased risk of breast cancer, this is very common question that patients ask when they come in to talk about hormone. My grandma took hormones and she got breast cancer, and I don't think I want to take hormones because it was from her hormone replacement therapy. Back in the day, 20, 30 years ago, we gave women synthetic progestins. So this is going to be norethindrone acetate, medroxyprogesterone acetate. There's a lot of different names for these progestins. Those synthetic progestins did in the studies slightly increase the risk of breast cancer in the women that were taking estrogen and progesterone together. There is a natural progesterone. It's called micronized progesterone, and it comes in a capsule form. That one can be taken orally. And if you are a woman that has a uterus and you are taking estrogen replacement therapy, you need to take progesterone with it. Okay. You should never, ever, ever, ever take estrogen by itself if you have a uterus. And that's because estrogen is proliferative, progesterone's anti-proliferative. So for protection of the uterus, protection against uterine cancer, if you take unopposed estrogen, you could develop uterine cancer. Just because of the estrogen replacement. So that one comes in a capsule form. I have patients take it at night. It really has a sleep-like effect about 30 to 60 minutes before bedtime. And that protects the uterus, but it also does a few other things. It helps with sleep. It's a great one for perimenopause for patients with estrogen dominance.
Okay.
Crazy levels of estrogen, horrible periods, some nightly oral micronized progesterone calms the bleeding down, gets them sleeping better. So I like progesterone in perimenopause, but it also is very calming to the brain. So you in your line of work, what you do, right? You see a postpartum patient and she's like, I'm anxious, I'm unnerved. The same thing happens in perimenopause because one of the metabolites of progesterone is called allopregnenolone. It affects GABA in the brain. And so when you give progesterone, it's very calming to the brain. So sometimes these women are like, all of a sudden I've got this horrible anxiety. Progesterone's very calming and it can make them feel.
Which is why our postpartum women should be having access to that.
Yes.
That's a whole nother
talk. It's actually funny that you bring that up. So I was just telling a patient in clinic, the postpartum period, especially for a breastfeeding woman who's making tons of prolactin and driving her estrogen down, right? It is basically a menopausal state. Postpartum women are basically menopausal. And when you think about that, you're like, whoa, right? Vaginal dryness, anxiety, depression. Some of them are having night sweats. This woman was like, I woke up sweating the other night. I got up to breastfeed my baby and I was soaked. Postpartum is basically a menopausal state. Now, obviously, we can't just throw hormone replacement therapy at all of them because they're trying to lactate. And so, but that is a very important comparison to make, is that it's the same physiological symptoms that they're experiencing.
Yeah.
Yeah.
Well, and there are some medications that are coming out. We just don't have access to them as average.
Yeah.
Average
Well,
person.
one of the treatments for postpartum depression is an IV infusion that is a metabolite of progesterone.
Yeah. And most of my patients can't afford it.
Oh, it's like $30,000. Yeah. Well,
sounds great.
You can just use progesterone. The trick is there are some studies that say it could maybe impact the milk supply with lactation. In my clinical experience, I've never seen it happen.
Good to know.
Yeah.
Okay.
Yeah.
So beyond medication, chat with me about the role of nutrition, lifestyle changes, stress, all of that, because I know that is that plays a really big part, and it's obviously really important to you, the lifestyle that you live.
And it becomes more important than it was, 10 years prior. So when it comes to nutrition, we start to see metabolic changes with loss of estrogen that increase insulin resistance. And so when it comes to a dietary strategy for perimenopause, the most basic advice that I give people is you probably need to start eating more protein, because the amount of protein required with a meal as we age, the amount of a specific amino acid called leucine, is required to stimulate muscle protein synthesis. So to protect our muscle tissue, our lean tissue, as we make this transition into perimenopause and menopause, we need more protein with each meal. And what most women are doing is they might have 1 or 2 eggs, they're having a protein bar, they might have some chicken on their salad at lunch, but they're never getting the amount of leucine required to stimulate their lean tissue. So in a day, you should never be eating less than 90 grams of protein. And ideally, with the first meal and the last meal of the day, you should be getting 30 to 50 grams,
Okay.
which sounds like, oh my gosh, Dr. Seeman, that's like a huge amount of protein. But really, when you think about it, 4 to 6 ounces of chicken, steak, beef, fish, you'd have to eat quite a few eggs. But you can supplement too, with protein powders and things like that. Ideally, whole food protein is best and most optimal. But most women are under eating protein. Then I think of protein like the little Lego blocks. Like if you're going to build Elsa's castle, if you're missing Legos, like you're not going to be able to build the castle.
Okay.
So eat the protein so that you have the structure to build the castle. Fat and carbohydrates then are basically your energy sources. So most patients have trouble finding the balance between fat and carbs in the diet. And that's because most modern American processed, quick, easy food contains either a ton of carbs or a ton of fat, or it's usually a combination of the two because they taste really good when they're together.
Tastes good.
And it's usually a low protein food. So unfortunately, most people are overeating energy calories and they're not eating enough nutrients. So we kind of use this term overfed and undernourished.
Okay.
So we're generally eating enough, energy for the day, but we're not getting the nutrients we need. So we need to start looking at the nutrient density of the food. So most high carb foods, breads, pastas, grains, have a lot of energy, but they don't have a lot of nutrients in them. So I tell women, start taking the bun off your sandwiches, maybe put the protein on a salad. There are ways to kind of slowly reduce some of those simple carbohydrates. And of course, the lowest hanging fruit is like if you're drinking fruit juices and sodas or, eating candy or a big bowl of ice cream every night. And then when it comes to the fats, it's the quality of the fats. So most women are consuming really low quality fats, a lot of, vegetable oils, canola oils, fried foods, and they're not eating nutrient dense things like butter or olive oil or, eating a nice ribeye steak. So nutrition can be very confusing, especially if you go to social media. But the most basic thing is, first of all, how much are you consuming? Are you really watching what you're eating? Because portions can get out of control pretty easy. Increase the protein,
Okay.
and watch the simple carbohydrates. And then exercise. Women are, most of us are not moving our bodies enough. That's just one thing. But when it comes to exercise, if you're going to carve out some time in your life to do it, weightlifting and resistance training is where it's at.
Tell us more.
And if you've never done it before, it's okay. Now is the time
Okay.
to start, because cardiovascular exercise is great. It's great for our cardiovascular system, but it doesn't move the needle when it comes to body composition. And most women, what they really want is, right? We talked about it. They're like, I gained 10 pounds and it's all around my midsection. If you want a better body composition, you should focus on getting strong. Not on losing the 10 pounds, but on getting strong. And it's likely to improve itself in ways that you never saw before. Resistance training is the only non-pharmacological method that's been consistently shown to offset the age-related changes in our skeletal muscle mass. So loss of strength, loss of power. And what happens as we go through perimenopause and menopause is we become frail. We become weak. You think about your grandma, right? She has to push on the chair to get up out of the chair. And that is the last thing we want, because not only is muscle the greatest disposal agent of glucose in the body, so it's a metabolic organ. I mean, muscle, if you like to eat bread, you better maintain some good muscle mass. I'll tell you that. And that's from a former pre-diabetic. But it also, decreases our chances of falling and breaking a hip as
Yeah.
we get older.
Every old person in my family gets osteoporosis.
Osteoporosis. Your muscle mass is directly related to your risk of dementia. So when you do resistance training, when you flex those muscles in that way, it creates a stimulus that talks to your brain, it talks to your heart, it talks to your fat cells. So women are very intimidated by weightlifting now.
Yeah.
They've never done it. They've never, seen somebody do it. They go to the gym and it's all these like, big 20-year-old guys doing bicep curls in front of the mirror. But the amount of work required to see benefit is actually quite small. There was a study, I talked about this in my TED Talk, of women 65 and older. They did a resistance band program for 8 weeks, and they saw massive improvements in every parameter that the scientists were looking at. So, you can start with body weight, you can start with resistance bands, you can sign up for a class with your girlfriends, because I like to work out socially. Like I have a great home gym and I don't do well going down there by myself. I want to be with people, right? They push me.
Yeah.
It can be kind of a social hour too. But resistance training is going to move the needle with body composition the most for women.
And I do think we have this idea of, for women, like I either need to be on the treadmill, outside running, or doing like a cardio class, which, as you mentioned, the social aspect, I'm like, none of those really allow
and
for
all
connection.
movement is good movement.
Yeah.
You've got to figure out how to incorporate some weightlifting a couple times a week for your muscles and for your bones.
Yeah.
Too.
Okay.
Yeah.
Great.
Yeah. And then the other things, sleep has to be addressed. If you are not sleeping well, it will start to impact. You're gonna start to be more hungry. You're gonna start skipping your gym sessions. Sleep is so important, and it becomes more important as we age and as we enter perimenopause and menopause, because that's when sleep disturbances start to become a real issue.
Yeah.
For people. And then the other part of it is nurturing our parasympathetic nervous system. We live in such a fast-paced, gas pedal, go, go, go kind of life. And we need to start to incorporate, some time away from our phones, doing some breath work, doing some meditation,
Yeah.
getting into our parasympathetic nervous system, because our body is stressed. We're starting to lose our hormones. We're starting to age. We're losing our resiliency. And so there's a lot of places that women can kind of spend their energy. And so most of the time what I do with patients, I'm like, let's choose one. Let's work on this one. Once we feel like we got that skill down, let's start to incorporate. You don't have to bite off more than you can chew, because it can seem overwhelming.
Totally.
But these things are very important when it comes to perimenopause and menopause.
Yeah. And I'm the same way with the women that I support, where I'm like, okay, let's go over what our goals are, and then let's choose one, and let's really just hone in, and a lot of those lifestyle changes. Like, I'm just going to focus on sleep. Sleep is one that I always encourage folks to. I'm so protective of people's sleep because it impacts everything, but especially our mental health. And I find that when women are trying to make multiple lifestyle changes all at once, that is a really quick recipe for burnout and giving up, and like, this is too hard. So if I can make one lifestyle choice at a time, really get into a routine of it, feel like it's, part of my everyday life, then let's add in the next one.
The other important thing too is, like, back to the conversation about hormone replacement therapy. If you have, if you're sleeping poorly and you're inflamed and you have prediabetes, and you just think pouring estrogen and testosterone into that system is going to fix it, it won't. And so sometimes, women have to understand too that hormones are fantastic, but they only work well in a system that's working well.
Yeah, gut health, is that what you're looking at?
I mean, all of it. I mean, it's all connected. The body is an amazingly but very complex system. And so, all of these things need to be a piece of the puzzle, not just one of them.
Let's get into some listener questions. Why does undiagnosed ADHD present itself in the perimenopause age range? This person said, just diagnosed with ADHD at 42.
Well, it's possible you've had it for a long time and you've found strategies around, some of the symptoms that you're having. But we've kind of talked a little bit about the physiology of the brain, and that as we start to see erratic levels of estrogen, progesterone, testosterone production, it does actually change a lot of neurotransmitters in our brain. And so it's a common time to see not just ADHD, but other mental health disorders kind of, pop up, because GABA and glutamate levels are changing, serotonin's changing. You're going through different chapters in your life with, I've seen women who suddenly have career changes or their kids have graduated and left the house, and then all of a sudden it's unmasked, some of these things. But it is actually a very common time that women will get diagnosed with some of these things
Hmm.
that they've likely had for a long time,
Yeah.
and perimenopause has kind of unmasked it.
Yeah. And what I see in my practice is so many women are getting diagnosed after their postpartum period. And I kind of give them a similar example, which is you've probably already had it, but you've had these systems in place that have worked well for you in order to manage all of your responsibilities. And then you have a human that you're in
Yeah, you're
charge
kind
of,
of busy.
along with hormone changes. And so those systems no longer work for you. So
Yeah.
you are just seeing an exacerbation of what you've already had,
Yeah.
but you're learning that those things that you had in place don't work.
And the studies show, thinking about like my girls are 23 months apart, but the studies really show it takes about 3 years between pregnancies to replete the nutrient deficiencies that are caused by pregnancy and lactation. And there's some studies that show some brain chemical changes that can last up to 6 years postpartum.
Wow.
So yeah, you put that, you now there's a baby in there. Now there's like all these different dynamics, and then you have all of these changes happening in your body, and it is a whole different chapter for sure.
Absolutely. Next listener question. What are some early signs that I need my hormones checked?
Well, the first answer is you don't always need your hormones checked. But if you're starting to see a big red flag is like dysregulation of the menstrual cycle. So as an OBGYN, the menstrual cycle to me is like a vital sign. If you are not having a regular cycle, the cycle length, the number of days that you bleed, the amount of flow that you have, if that doesn't seem normal, something's off.
Okay.
So that's a huge red flag to say, I need to see somebody and
Well,
get,
and just to add,
your
I see so
blood
many
work.
women say, like, I've had this change in my period, which may not seem abnormal, but it's not normal for me.
Yeah.
And I'm like, your cycle.
Yeah.
You've been having it for how
All
long?
of a sudden I'm bleeding for 7 days and I used to bleed for 3,
Yeah. Or I'm going through tampons
Yes.
rapidly, and I've never been that
Or the
sick.
opposite end of that. My period is very scant. It's very light. It only lasts like 1 or 2 days. You
Yeah.
might not have enough estrogen,
Yeah.
right? So I think the menstrual cycle is a big one. Sleep disturbances are another very common one. Um, but the menstrual cycle is the biggest one.
Okay. And this question is, who are local either doctors or physicians that take perimenopause seriously and are okay with treating symptoms and not just telling women they are getting older?
Yeah, so I would go to the North American Menopause Society and find a board certified practitioner. Like I said, there probably are others,
Yeah.
out there that just have not done the board certification, but I think that is a good place to start because you know that this person has had more advanced training. They've literally sat for a board examination, so they've answered all the
Yeah.
questions. They know, what the science really says, because there are a lot of practitioners out there that are probably leading some women astray. And that's, unfortunate. But I love that this conversation is happening. And actually, a lot of my colleagues here in Omaha have now gone back. They didn't really care as much about menopause until this conversation started up.
Yeah.
They're all going back. They're getting board certified. They do. They truly, I think, do want to help patients.
Absolutely.
I really believe that in my heart of hearts that most doctors really are trying to do their best. But you kind of said it earlier in the podcast. As an OBGYN, I think sometimes people think we're a gastroenterologist and a psychiatrist and a cardiologist and an obstetrician and we are kind of in a sense in primary care. But there is a whole host of physicians that, in the last 20 to 30 years, hormone replacement therapy was just like not anything we did, and menopause was understudied. And so they just don't have the tools, but there are good providers out there if you go looking.
Great. And then as a girl mom myself, I would love to know if you have any wisdom or guidance on how you're preparing your own daughters just to know about their health, their cycle, and
Yeah.
how to take good care
Yeah.
of themselves.
Well, our house is obviously our kitchen table discussions are probably crazier than most. I have been just the most open book to my 3 girls, about how their bodies function. We've talked about sex. We talk about the menstrual cycle. There are like literally no secrets in my house.
Yeah.
And of course, because of what I do, it's easy for me to have those
Sure.
conversations, but I think probably for some moms, it's not. I'm actually in I don't know when it will happen. I can't make any
Okay.
promises,
Uh,
but because of my daughters, I'll be working on an online course that moms and daughters can go through together to kind of learn about their bodies and learn about
Yes.
menstrual cycle and all the tough conversations about birth control and periods and things like that. A common question I get is, when should I bring my daughter in,
Okay.
to see a gynecologist? Because most girls are going to see their pediatrician until they're 16, 17, 18. I do see patients even as young as 10, 11, 12, 13. Once they've started menstruating, if they're having problems, it's okay to bring them in. We generally don't do any sort of touch exam at all the first time they come
Okay.
in. We just talk. That makes them a lot, more comfortable. Most of the time I can get, right, the patient tells you the answer. Most of the
Yeah.
time I can get all the information I need talking to the mom and the daughter. If a mom feels in any way they want their daughter to come in to talk about contraception at any point, I'm always there to have those tough conversations. And sometimes moms stay in the room, and sometimes moms and dads don't, and they
Yeah.
wait in the waiting room. The first Pap smear doesn't happen until age 21.
Okay.
So usually I'm seeing girls before they go off to college, just to arm them with all the information they need as a woman, kind of going out into the world and,
Yeah.
you know, talking about their periods and birth control and things like that. But I think once again, with social media, we're seeing a lot of dissemination of information. And unfortunately, the younger generation is using things like TikTok and Snapchat. And sometimes I just cringe at the information that they're hearing.
Oh, yeah.
And so, we're always trying to put good content out there for them as well. But
Hmm.
sometimes what they see on social media is also,
Not
hurtful
the
or
most
untrue or not the best information.
reliable.
So I think it's really good as a mom to create that trustworthy relationship with your child, that you
Yes.
can be, a resource, an open book, a non-judgmental,
Hmm.
resource for them. Because I think sometimes it's hard to remember we were a teenager one time.
Yeah.
I could take my mom hat off for a second and just, connect with my
Connect.
daughter, because that trust is so important when it comes to things like this.
Yes. And so my girls are 4 and 7, and the amount they already know about periods and bodies is probably more than, a lot of other families in
Right.
comparison. But one, I am a mental health therapist. And so, and also like we have a very open family. And so like they come to the bathroom with me. And so
Yeah.
they know, my husband's like, why do they know so much about, I'm like, because I'm never alone. Like
Yeah.
they know what tampons are. They know about period. They
Right.
know mom bleeds at this time. Like they know they need to know these things because
Right.
it's going to happen to them
Right.
too. And so we're starting those conversations and normalizing it and using appropriate body terms, just like we talk about
Yes,
elbow, knee,
100%.
whatever. Like that's your
Yeah.
vagina.
Yeah.
We just
Oh,
start
and that's
early on
actually a
that.
big one. So the labia, the outside is called the vulva.
Yes.
Yes. And so many people say vagina, but it's the vulva. You can't actually see the vagina. And so it's so funny because I, obviously told my girls all of this. And so when they went to their little class at school, they're
Yeah.
correcting people. They're like, that's actually the vulva.
Yes.
Um,
So this makes me feel very uncomfortable because I started with using vulva and everyone in my family
and
was
they're like, what are you
like,
talking about?
that, like that's, and so I'm like, whatever, just call it the vagina. I tried, but
Yeah.
yes, it is the vulva.
Yeah.
Well, thank you so much for joining us. I know that one, your schedule is packed, but I know that so many people are going to walk away with this information and feel more informed and empowered. Where can listeners connect with you and learn more about your work and all the information that you're sharing with
So
folks?
I'm most active on Instagram. It's Dr. Fit and Fabulous. It's spelled out DOCTOR Fit and Fabulous. I have a website, www.drfitandfabulous.com. Once again, spelled out. That is a great place you can find connections and links to the podcast, to my book, and other resources and things like that. I love hearing from listeners. I thank you for the opportunity to just come and chat, because there's, like I said, social media is a crazy world out there,
Yeah.
and we're trying to just do our best to get good information out there for
Yeah,
people.
yeah. Well, not only do I appreciate you, but I know our Omaha community appreciates you. So many of my personal friends have reached out to me and said how much they love you, that you're their OBGYN, and are so grateful. So I'm so glad that not only are you supporting our community, but you're connecting with so many others through
Yeah.
these other
And
platforms.
locally, I'm at Mid City OBGYN, and we've got two locations, one in West Omaha, one at 72nd and Center. I go to both locations, and like I said, I see everybody from young teenage girls all the way through menopause and beyond.
Perfect. Thank you. Well, thank you so much. And to our listeners, If you feel like this conversation has been helpful for you, please share it with another mom or woman that could benefit. Remember that knowledge is power. You know your body best. If you're feeling like you're just not feeling like yourself, please advocate for yourself. Take the time to invest in yourself. Caring for yourself is caring for your family. Until then, we'll see you next time. Bye.